Hi everybody, thanks so much for joining us. Thanks for having me here. I'm Dr. Shadi Rickman, I'm a board certified small animal surgeon, and I do want to thank Telementorship for sponsoring this talk. Please do visit them at booth 330 and have a chat with them. They have incredible products there, so please do that. And again, thank you to Telementorship. Before we get started, I just want to know how many folks here are veterinarians that have graduated in the past 5 years? Nice, good. How many folks here are veterinarians beyond 5 years now? Okay. So some of the stuff that we're going to talk about here is going to be tailored towards the newer graduates. And for those who are seasoned, hopefully you'll take away some words of wisdom, let's say, from this talk. The proceedings that I have for G.D.V are quite comprehensive. So if you haven't looked at those yet or haven't received them yet, when you do, it's like 40 pages, in-depth research that I've done through PubMed. So that's way more academic, more nuanced. This is meant to be more of a fun, clinical, practical look at G.D.V, which is of course a very common disorder. So that's the intent here with it, and any and all questions are of course welcome. So a little bit about me. I graduated from Cornell University in 2006. I then did my general internship at Angel in Boston. From there, I did the majority of my surgical training at Long Island veterinary specialist, 2 surgery internships, 3-year residency, passed the boards. And then from there, I moved out west, where I practiced in Las Vegas, and then Silicon Valley, LA, and then currently I operate VetTriage, which is a 24/7 global telehealth platform that we can talk about if anybody's interested in telehealth. That's currently where I'm at. This is a long outline, and we're going to go through everything here today of G.D.V, so we'll tackle all these topics. So a bit of statistics here. The prevalence, 2.4 to 7.6 for every 1,000 dogs admitted to a hospital have G.D.V. 15% will die of G.D.V in their lifetime. There's between a 4% to 37% lifetime risk. It usually affects middle-aged to older dogs. Usually, of course, are large breed, deep-chested, German Shepherds, Great Danes, Standard Poodle, and so forth. There are plenty of risk factors. The proceedings you have goes through a host of risk factors. Some of these risk factors that are in the proceedings are not that relevant in my opinion, but I tried posting here the ones that I typically have seen in my experience with this. So things like advanced age, breed, eating a low number of meals per day, temperament, usually those are a bit more high-strung or anxious, are more prone to G.D.V. Being active after eating or stress after eating, having a family history of G.D.V, history of splenectomy, which we'll talk about, having a gastric foreign body, and then of course deep-chested dogs and genetics play a role. So it's obviously a multi-systemic, complex disease. Despite being so common, there's still a lot of questions that we don't know about the condition. And who knows how it starts, right? Do the dogs bloat and then volvulus, or are they tours and then bloat? We don't really know. Either order seems to play a role here. They are, of course, para-acute or acute in their onset. However, I do believe there's a subset of dogs that are chronic GDVs. I call them chronic bloaters. These are the dogs that walk into your clinic completely stable with a GDV. And if you press the owners on the history, I'm convinced that if you talk to them about the GI history of this dog, there have been situations where they show clinical signs that may have been GDV related and then self-resolve. And then it would happen again and then self-resolve. And so I believe there is at least a subset of dogs that have some sort of chronicity with this, but of course the majority, the most common scenario we see are the para-acute to acute GDV. And then I'm not as convinced that they're all idiopathic. I know we call it that, we don't know what happens, whether it's genetics related or anatomical, whatever it may be. I do think that if you did a deeper diagnostic workup on these dogs, you can find something. I've had dogs that have had emergency paralysis at the time of the GDV, pulmonary masses, liver masses. I'll find something wrong. Now, are those other comorbidities related to the GDV or are they separate? I don't know. But it is curious that sometimes I will find other conditions in these dogs. And so I just am not 100% sold on the fact that they are all idiopathic. And of course, trying to figure that out is going to be difficult. We need literature to support that claim. I'm willing to bet that a deeper workup on these dogs would show a primary condition. We typically don't, because these are para-acute, acute surgical emergencies. And so we do the bare minimum to get them into anesthesia, surgery, and cut them to save a life. So they don't always get a thorough workup, especially if you're cutting in the middle of the night. Average rotation between 180 to 270 degrees, usually along the long axis in a clockwise direction. The pylorus squamatum gets displaced, dorsal to the esophagus, you end up with esophageal obstruction, pyloric dysfunction, and that's, of course, the G.D.V. And from there, the dog is affected systemically with the condition. So from there, you have a whole host of factors, right, that affects the dog systemically. It's not just a GI issue at that point. So these are all the things that occur, and some of the points I want to emphasize here. We do see bacteremia in 40%, so of course that might be the basis for sepsis in these dogs. Hence, antibiotic coverage for them is going to be essential, because with vascular compromise of the small intestine, bacteria will translocate, and that sets the stage for something like sepsis to occur. So you do want to cover them with antimicrobials. I know antimicrobials come under question, of course, with bacterial resistance, but consider that. And then from there, of course, multiple body systems will be affected. Vascular necrosis of the stomach, 10 to 30% of these dogs, and that, of course, to me is a horrible prognosis. We know that from the literature and my own experience. We see that. And then eventually the heart becomes affected for a variety of reasons. You'll end up seeing cardiac signs. So we're all familiar with the signs of G.D.V. You have an middle-aged, older, deep-chested dog with peracute, non-productive retching, vomiting, gastric dilatation, a whole host of issues. And so from here, we're going to talk a little bit, this is more targeted towards maybe the newer graduates, regarding diagnostics, because radiographs, even with AI and teleradiology, all these things, the new graduates still ought to have experience with reading radiographs, just the sort of basics behind it. And so I'm going to emphasize a few things here. When you're looking at a lateral radiograph, as depicted here, there's the stomach and there's a gastric axis. And so you can tell based on diseases that are affecting the abdominal cavity, based on displacement of the stomach, what might be happening there. I'll show you examples. I also want to point out that the first gas opacity just called to the stomach is always transverse colon. So a lot of times, especially the newer graduates, they might see a gastrical structure just called to the stomach and try to figure out what is that. Always transverse colon, always transverse colon. And again, we're talking about anormal diagnostic workup with abdominal radiographs. So don't be confused by that. Transverse colon sits just caudal to the stomach, and then when you have changes to the stomach, the gastric axis is going to change. So for example, the liver is kind of small, then the stomach, the gastric axis is going to move cranially. Or if you have like a mass associated with the liver or the cranial abdominal cavity, then the stomach is going to be displaced caudally. And so there are things for the new grads to keep in mind when you're looking at abdominal radiographs, because it can get very confusing, especially when things get kind of messy. And I apologize for the poor quality of the radiographs. I stole these from Google, but I want to make the point of the gastric axis. And then you have things like this, where you're looking for the severe gastric dilatation, the mucosal folds, and displacement of the normal anatomic structures of the stomach. I also want to point out, when you are interpreting radiographs, again, more for the newer grads, look at the entire radiograph. You have here spondylosis, right? A lot of times these are large breed dogs, middle-aged to older. They're going to have other things wrong with them. Even though they not matter for the G.D.V, you want to be thorough when you're reading your radiographs, interpreting them, to look at the entire picture. Same thing here. This is a massive gastric dilatation and volvulus. We have spondylosis of the vertebral column. Note that in your record. Look at the pulmonary cavity, right? You still want to look at everything else on a radiograph, and of course the right lateral is the image that you're going to choose. If you had to pick one image, right lateral. Ideally, you'd have a 3-view thoracic radiograph collected for metastatic screening, and ideally, I think 3-view abdominal radiographs too. But again, bare minimum, right lateral. And with a G.D.V, you'll be looking for this soft tissue structure here that's delineating the compartments of the stomach as the stomach is torsing. You also have, again, bridging spondylosis of the vertebral canal and diffuse small intestinal ileus. So this is for the purposes of the new grads to write up the radiographs as thoroughly as possible. So another example, just be thorough when you're looking at your radiographs. And then, of course, you're trying to think of, well, is there anything else going on? How do I know if there's like a gastric perforation? Is there going to be a pneumoperitoneum? These are, of course, tricky things to look at as well, and I'll show you some examples of that. Your classic G.D.V, compartmentalization of the stomach. So just to drive the point home, and then you have some situations where it's like really crazy. We do see in dogs, of course, gas bloats and food bloats, which are different entities in a G.D.V. They are the bloating without the volvulus. And so sometimes you look at radiographs like this, you think, I don't know, is it a G.D.V, is it not? You want to combine it with your other views, you want to combine it with the history, and try to make a determination of whether or not this dog has to be cut now, which would be the case with the G.D.V, or if it's a food bloat or a gas bloat without volvulus, those are typically medically managed. And so it depends on the whole scenario. Don't get tunnel vision with these cases. look at the entire case as a whole. And I wanted to show the same animal here, same dog, with three view abdominal radiographs for a G.D.V, because we often don't see the other views. We typically are collecting our right lateral and then going into the operating room. So this is what a dog may look like with a G.D.V from all three views, and so just to be even more thorough. And again, you describe the entire abdominal radiograph, fluid-filled, small intestines, dilated, anything else wrong with the osseous structures, pulmonary structures, make sure you're thorough with it. And then you have insanity like this, where you've got probably a gastric perforation or some kind of GI perforation. There is an intense amount of pneumoperitoneum, there's all this air, and you know that because you can see the air in the abdominal cavity as well as the very well delineated GI tract, liver, everything's very crystal clear, and that's typical because of the contrast with the air around the abdominal cavity. This is, of course, an extreme view of pneumoperitoneum, but sometimes it's not so clear. And your first sign of pneumoperitoneum, especially if it's mild, is going to be this clear delineation of the diaphragmatic muscles. So this very thin line here is the diaphragm, and it's being outlined very nicely because there's air that's escaping the, presumably, let's just say GI tract here in this case, I don't know for sure, but there's air escaping somewhere, and it's pointing out the diaphragm very clearly. This is a very tricky area to look at in the abdominal cavity because also the lungs are going to overlap with this area. So it's tricky, but you're looking for these kind of subtle signs in combination with the case itself. And of course, in the case of G.D.V, you're thinking, well, there's pneumoperitoneum, then is there a gastric perforation from vascular necrosis? And that may or may not change the prognosis for that patient or what that client wants to do. Again, it's tricky, right? A small amount of air right at the diaphragm, the muscle of the diaphragm there, and so that's suspicious of pneumoperitoneum. And then there's, of course, going to be torsions of the intestinal tract as well, small intestine, large intestine, both. These are not common. Mesenteric torsions, they're not common, but they can occur, and they'll present in a similar fashion with a critical animal. They're not always the same breeds. They're effective in G.D.V, but just when you see things like that, you call it what it is, and you have to deal with it. And of course, an extreme example of that, right? So there's another example of a volvulus, not gastric, but this would be one that I would consider a mesenteric torsion probably in this dog. Oh, and that's just the BD for G.D.V, because we don't really get to see that too often. And then sometimes, unfortunately, you end up with three-dimensional imaging for G.D.V. You know, a chronic G.D.V comes in, he goes to a specialty center, they work it up and can't figure it out, it goes to CT scan, and you're like, oh, look, a G.D.V on CT scan. It happens. Stable animal, stable dog, G.D.V. And so on a sagittal view, or rather transverse view, CT scan, you've got your massive stomach here, duodenum, esophagus displaced, and then I think this is the sagittal view, large stomach. So, you know, you prefer not to have that not happen, but it does happen on occasion. Sometimes your basic diagnostics don't really get to the answer. And so this is a bit of a self-plug here for Vet Triage. We started a telementoring platform for Vet Triage Pro. So for those who are newer and who are desiring a mentorship, which we now know is the number one reason for a veterinarian to choose a job coming out of school is mentorship opportunities. Contact me. We'll talk about Vet Triage Pro, where I have a seasoned veterinarian talk to a new grad about any case or client communications, what have you, and we get you set up. And so that's why I want to make sure this talk is tailored towards the newer graduates, because mentorship is a problem these days. And so when we partner with Vet Triage, these are examples of hospitals that are partnered with us. They have my logo on the website. They have a synopsis of how we can help either the client for triage purposes or the doctors for mentorship purposes, and we create a whole landing page for them. I'm going to breeze by this because it's not the point of this talk, but I just wanted to show you that we can help the seasoned veterinarians out with Vet Triage Pro as well. So keep that in the back of your mind as well. This is an example of that. So this is one of my doctors on Vet Triage, and here's a new grad, and she's talking to him about a pre-check TPLO, and so just replace it with a G.D.V. Maybe it's your first G.D.V out of school, you don't know what to do, you don't know what to talk about with the client, how do you phrase the stuff, it's going to cost thousands of dollars, or maybe you're not comfortable cutting, if the nearest surgeon is miles away, or whatever it may be, and so you may want to run the case by somebody. And so we have this service as well for the newer grads to try and help the profession, because we are struggling with the veterinary shortage, and we want to keep veterinarians in the profession loving it for as long as possible. So this is just an example of a really cool interaction with my doctor and a new grad. Talking about TPLO, watching the dog walk. She shows them x-rays of the patient as well, so just to mention that as well. And then for the new grads who are nervous about talking to clients, realize a lot of what you're doing a lot of what you're communicating to the client is nonverbal, right? What's the tone like, the vibe in the room? Where are your eyes? Where are your hands? What's your body posture? Are you sitting up? Are you standing up, sitting down? What are you doing? It counts more than the verbal. Verbal is very important, of course, but you're talking about a life-threatening condition, surgical emergency, G.D.V. You need to be sensitive to the fact that every client is different financially, culturally, all that stuff matters. And so for the seasoned vets in the room, this is cakewalk. It's routine. For the newer grads, it matters. And so we're going to get back to G.D.V. I promise. This is meant to help the new grads with client communication. Where you don't want to have a dog on an exam table while you're sitting down, the owner's worried about the dog jumping off, trying to focus on you, but the owner's focusing on the dog too. This is maybe not the ideal way of communicating with a pet owner during a crisis like a G.D.V. Same thing here. You have the dog on the table, the client's trying to hold on to him, you're trying to show him radiographs, the client's kind of listening to you, but kind of focusing on Fluffy here, maybe not the best way to go about it. Maybe sit down, have a chat in a more comfortable position, dog on the client's lap, you're talking to the client about a condition that could be life-threatening, even emergency surgery, it could be expensive, or maybe even this. I love this kind of thing. You're sitting side by side with the client, you are on the same team. You're on the same team, looking at the pet is the goal, and you're both on the same team. You're not trying to convince the client of anything, you're having a conversation with them about what's happening with their pet. And this is even better. Now you are below the eyesight of the client, you're showing submission to the client, you're trying to not be intimidating. You want to tell them the sad news, they need emergency surgery now for their 10-year-old German Shepherd, and it might turn to euthanasia, it might not, we don't know. But you want to make sure that you're on the same team with the client and be next to them, be aware of these factors. The new grads are so focused on being doctors, as they should be, but client communication is paramount. And this is my favorite. You're on the same side with the client, showing you're on the same team. You're also kneeling down, so you're below the level of the client, and you're talking about the sensitive topic of emergency surgery. It's going to be thousands of dollars. Here's what we're looking at, and you want to try and create an experience that's positive even in a negative situation. So the reason why I'm pushing all this, guys, is because we're struggling in the vet space, right? We have a hard time keeping veterinarians in the field, and so perspective taking and seeking also requires us to draw upon cultural humility and recognize that our clients view their patients' care journeys through a unique lens that may be influenced by personal, familial, cultural, societal perspectives on the relationship with animals, the function and inherent value of the individual patient, as well as the uniqueness of their bond. We need to stop judging clients. You want to make sure that you are offering a spectrum of care. You talk to clients about a sensitive topic, and you want to be aware that even though you know what gold standard is, there may be a variety of options for pets, not necessarily G.D.V, but you want to be aware of that. So, little detour, back to our G.D.V. So, how many folks here cut G.D.Vs in their practice? Nice, okay, great. Of those who don't cut, how many are referring to emergency or specialty hospitals? Okay, so a fair amount of you do cut these cases, great. So, there's going to be steps to a G.D.V, and this is the same steps you have for any kind of critical case. But you're trying to assess the patient, talk to the client, and get intervention going with the client's permission, right? That's your goal. So there's going to be some combination of intravenous catheter placement, you're running basic blood work, collecting radiographs, but all this cannot be done without the client communication and them approving an estimate and authorization for treatment. You can't intervene until the client has had not only verbally but also in writing authorized treatment. So let's pretend they did that, or they're like, okay, assess my dog, what's wrong with my dog, he's very sick, I'm scared. I have a catheter, blood work, radiographs, and find out I've got a G.D.V, now you're back in the room again. Client communication. Okay, talk to them again. Okay, we found the problem within your dog has gastric dilatation-volvulus. This is a condition that involves X, Y, and Z. Here's the next step, and they want to keep going from there. More diagnostics, how stable is the patient, blood pressure, ECG, fluids, temperature support, pulse ox, analgesia if you need it, and then from there you're going into intervention. Now the client is approved intervening with the pet and possibly going to surgery from there. Or gastric tubing, or troperization, depending on what you have available to you and how emergent it is at your facility. Then, of course, anesthesia, getting ready for surgery. If you work with a surgeon, you're probably calling them in while the animal's getting prepped. If you're cutting the case yourself, you have your team in the back prepping the pet while you're maybe handling phone calls, seeing clients in exam rooms, whatever it may be, and then you're going into surgery. Surgery, although very important, is a small part of this entire picture, right? You're trying to stabilize the patient, diagnose the patient, talk to the client, back and forth the exam room to the dog, back to the exam room. Surgery is a small part, very important part, but a small part of the entire process. And then, of course, the post-operative care from there. How the patient do after anesthesia, develop any complications, what kind of monitoring afterwards, and continue reassessing, continue client communication. So this is going to be a multi-step process with these patients. We're not going to go through detailed stabilization, although we can if you have any questions, but typically we're talking about high volume of fluids, maybe colloidal support, usually 2 large catheters, and some kind of gastric decompression. I'm a fan of orogastric tubing. I don't trocarize, but trocarization is in the literature. It is approved for this type of condition. How many folks here do trocarize their G.D.Vs? Okay, yeah, a fair amount of you, yeah. And so usually if someone's going to trocarize, this is a hospital that I'm working at, it's going to be the ER doctor probably. Otherwise, when I come in, I'm sedating the dog while also passing an orogastric tube at the same time to decompress them. Or sometimes I'm doing it in surgery, in intra, as I'm making my first cut into the abdominal cavity. My technician is passing an orogastric tube. So I typically am going that route, but it depends on how you're set up at your facility. And so here's an example of passing a tube. Now sometimes the animal is so obtundant, so critical, that you might be able to pass the tube without sedating them and protecting the tube by putting medical tape in their mouth and then passing a tube that way. Before you pass the tube, you want to measure it. You're trying to measure it to somewhere around the last rib, and then mark it on this end, and then pass it through. So sometimes you're so sick you can do this. Otherwise, you're typically doing this under sedation or full anesthesia. And of course, we're all familiar with this, but this is how the stomach's going to rotate. Volvulus, it's going to pull in the omentum, it's going to pull in the spleen, and from there you've got your typical G.D.V. And of course, if you're going to rotate back into normal position, you're going to move the stomach in the opposite direction. So you're trying. So on this portion here, see where the duodenum and the pylorus went beneath the stomach. Your goal is to put one hand on this end to grab what you think is the pylorus, while the other hand. So again, I'm going to speak from a right-handed person. You're standing over here. You're a right-handed surgeon. Your right hand on the stomach. Left hand is a right hand on the fundus or body, depending on how much of a volvulus it is. Your left hand is trying to find the pylorus. You can't see it. You're grabbing blindly, and then as your left hand pulls gently up towards you, your right hand is pushing on the dilated portion of the stomach, and then hopefully you get that quick flip, and then all this gas and food comes out of the orogastric tube that your technician is placed in the esophagus, and you're back to normal position, and then you can continue focusing on stabilizing the patient while also performing the gastropexy. And so that's the idea here. It can be a mess, right? We've all seen dogs that have had tearing of the gastric vasculature and the hemoabdomen. You've got the omentum is all over the place. It's a large dog, so all these organs are shouting at you. The intestines might have diffuse ileus, so it can be a very scary thing if you're new to this. So you're trying to keep in mind the anatomy of what you're trying to do here and have the other noise not distract you from what you're trying to achieve. So now we're in surgery, and the stomach can look like a variety of different things. You hate to see this. You hate to see gastric necrosis. I don't have a positive outlook on these dogs. I don't see this too often, thankfully, but also a lot of them in my hand just don't make it. Whether we're performing gastric invagination or a gastric resection, partial gastric resection, they just don't do well. I have heard anecdotally of some doctors, they'll see the compromised portion of the stomach, they'll leave it alone, they'll finish the surgery, reevaluate that intra-op, maybe it's improved, but usually if it's black leather texture to it, it's probably not going to improve. And I've had doctors, again, anecdotally, leave this, finish the surgery, wake the patient up, and then re-explore a day or two later to see if it's still there. And so, they've reported success with that. I'm not advocating that, it's not in the literature, it's anecdotal, a handful of conversations I've had with surgeons, but that's something to consider. And I'm okay with it because the prognosis is so bad with these dogs that whatever you can do to improve it, I'm fine with it, as long as you have a client who's on board and communicate with them what you're trying to achieve here. So, and then of course the spleen is going to be involved with it, right? When do you remove the spleen? When do you consider a splenectomy? And typically it's going to be something like either it's a splenic torsion, which would be obviously you perform a splenectomy from there, splenic rupture, or if you're palpating the vasculature, especially the main splenic artery and vein, there's thrombosis, there's no blood flow there, and it's kind of questionable, then you're probably considering removing the spleen. Always submit the spleen for a biopsy. As long as finances are not tight for that client, submit it for biopsy. These same dogs that get G.D.V also get hemangiosarcoma. And I'm not saying there's a causality there, but if you're going to remove the spleen anyway, because it's compromised, submit it for a biopsy, just make sure. That's my opinion on that. I am going to shout out here for valve floor retractors. How many folks here when they perform abdominal surgery in their practice use self-retaining valve floor retractors? Yes, okay, good. For those who don't and who perform abdominal surgery, I think it's worth the investment, even if you're just performing spays. So to the new grads, large dog sprays are nerve-wracking, and a valve floor retractor is phenomenal. It's going to make your surgery a lot easier to see everything. You can't always count on an assistant scrubbing in with you. And even if you have one, it can be a bit cumbersome with everybody's hands in there. A valve floor retractor is phenomenal, so I encourage the use of those. If you perform abdominal surgery frequently, even if it's only spays, it's worth investing in self-retaining valve floor retractors for abdominal surgery. We all know there's a variety of different pexies. Typically, incisional gastropexy is the one that I'm performing, and the majority of folks that I know, but there's all different types, and the proceedings that you have, it does compare what the strength is of each type. It just depends on what you're comfortable doing and how you were trained. And then as a preventative measure, of course, there's laparoscopic, which we won't talk about. That's not part of G.D.V treatment, but for prevention, at the time of the neutering of the stay, if clients desire it and you have access to it at your practice or as a referral, then of course gastropexy via laparoscopy is awesome, and there's a beautiful example of that here that you can perform at the same time with a young dog that's at risk. So something to keep in mind as well for those clients who want it. Now for the gastropexy itself, typically the majority of us are performing incisional gastropexies. How many folks here who cut these cases perform something other than incisional gastropexy? Okay, yeah, looks like nobody. So this is the most common preventative measure for G.D.V, and I'll give you some opinions of mine with this surgery. So if you're going to perform this surgery, you're going to create an incision in the abdominal wall and a corresponding incision in the stomach. It's not going to be over the pylorus or pyloric sphincter. You're going to be actually on the stomach itself. So typically you're going to be some centimeters oral to the pylorus. I say here's some centimeters, even though in the surgery books it'll give you a number. It depends on the size of the dog. I've had the occasional small to medium breed dog that has had G.D.V. It's rare, but it does happen. So anyway, it depends on the size of the dog. And also wherever you make your incision in the stomach, it's got to match up comfortably with the abdominal incision. You don't want there to be any tension. It's got to match up nicely. So that's the first point I'll make. The second point I'm going to make is when you're starting to perform your gastropexy, I find it much easier to start at the most cranial part of the patient, and you're starting with the deep portion of the pexy. So you start cranial and deep. That way, when you finish the deep portion, you're going to now tackle the more superficial portion, meaning the portion that's towards you, and you're not working in a hole. If you start caudally and work cranially, or you're starting superficial and then hitting the deep portion, you're going to now be in your own way. There's no point in doing that. It wants to be a quick surgery. So start cranially and then start perform your gastropexy going from from cranial to caudal, the deep portion first, and then you can go from cranial to caudal to the superficial portion. So it's two separate continuous patterns for the pexy, and that's a nice way to not get your own way, and you're aiming for a nice pexy there. The other point I'm going to make also here, my third point would be the use of towel clamps, sharp towel clamps. So let's say you don't have valve floor retractors, you don't have an assistant. What I find helps if you're going to perform the entire surgery yourself is take towel clamps, attach them to the abdominal musculature, not the skin, the abdominal musculature, and with one hand you can hold the clamps up, towel clamps up, and then the other hand you're doing the pexy with the needle holder. So that's a nice way of single-handedly trying to perform a G.D.V. if you don't have an assistant in there with you. Keep in mind when you do perform the gastropexy and you have a valve floor in there, you probably want to remove the valve floor retractors, then perform the pexy, and then you can replace them to reassess the abdominal cavity if you need to, because they're going to get in your way. If you're fighting the valve floor retractors while you're performing the gastropexy, you're going to have a loose pexy, and you're going to be fighting the tension that you're creating on your own. A towel clamps over the linea is a nice way of trying to single-handedly perform your G.D.V. And that's the example there. Towel clamps, and then starting from cranial to caudal, deep portion first, and then going cranial to caudal to superficial portion to make it easier on you. Here's another shout out, besides a splenic biopsy, liver biopsy. The same dogs that get G.D.V. also get hepatic neoplasia, hemangiosarcoma, and so so, again, assuming finances are not tied to that client, I recommend liver biopsies on all of these dogs. Doesn't matter if their liver enzymes are elevated or not, doesn't matter if the liver looks normal or not, I'm getting a liver biopsy. It adds only a few seconds to the procedure if you're experienced with this, and you just screen it. That's all you're doing is screening. So I recommend it, not required, but I do recommend doing it, and this slide is meant to show just all the different ways that you can collect a liver biopsy for these pets. So I recommend it. How many folks here that do these surgeries actually do liver biopsies at the same time? A couple. Yeah, so something to consider. Something to consider. And then with that, of course, I'm going to plug Vetigel. This is a Medicus product. I love this stuff. So hemostasis has come a long way. And if you see here, I have an example here of like a ligature type, bipolar sealing device, which I absolutely adore. But a lot of folks don't have that kind of device. And so you're going to use the guillotine method or a dermal punch biopsy to perform a liver biopsy or any other biopsy. And so a product called Vetigel is phenomenal for this type of hemostasis. You can use it for a variety of different surgeries as well, and I'm just going to show you a picture here because this is such cool stuff. So you have a area where you biopsy. This is the liver, and you can place this product on there to allow for hemostasis. I mean, I've used gel foam many times, and I've had it where it just falls off, or after I finish my surgery, it's just floating in the abdomen. I can't count on it. Something like this, you can count on. This stuff is so cool because it creates bonds between the patient and the product. So this is so cool. So something like this, if you guys perform a lot of surgery, vascular surgery especially, anything that requires some level of hemostasis, like I said, I have a whole list of different indications for it. Consider something like this. Visit their booth. This is awesome. This is where we're going with veterinary medicine. We need to be smarter about how we operate. Even though you might be used to a certain technique, there are better things out there that you can try for. And then monitoring. It's so frustrating to have a surgery that goes well, and then intra, and then post-operatively the patient doesn't do well because monitoring was inefficient, or insufficient rather, I should say. You want to have adequate monitoring after surgery, and it's very, very important. And it's a lot of times where folks will drop the ball on these cases. Do a great surgery, but you're not watching them after surgery. And we all know that, of course, monitoring a patient after surgery requires staffing, right? Someone's got to have eyes and hands on that pet. Well, I do think that telemonitoring, telediagnostics is the future here. It's just our hospitals are too busy, we're understaffed, and if you're performing surgeries like this, these patients have to be monitored 24/7. You don't want to miss something. You don't want to have your excellent surgery go downhill. So, again, it's another medical product. They do great stuff. VetGuardian is telemonitoring, and you can set up this device. It's based on thermography, and it'll monitor a variety of different parameters of the patient here: body temperature, pulse, respiratory rate, movement. It's combined thermography with a live camera, and it'll actually talk to your tablet, right? Stores everything in the cloud, and you can monitor the patient from a distance. You don't have to physically be there now. You can watch a critical patient from a device. You hook it up in front of the cage, and you've got eyes now on the dog, and that allows you to relieve your staff and monitor the patient at the same time. So telediagnostics are the future. This stuff is going to be the way of the world. So pet owners are already doing this. Pet owners are purchasing devices to monitor their pets at home. It's already happening because they want to monitor their pets. They're their children. And so in a hospital setting, we need to get up to standards now on the human side, comparatively, with telediagnostic telemonitoring. So I push these types of things because it is the way of the future. This is where we're going with this stuff. Especially if you perform a lot of surgery. And you can monitor multiple animals at the same time. So this stuff it's the way things are going. Whether we like it or not, pet owners are going to have access to diagnostics at home. And so this stuff, we can do it in the hospital as well. You're already doing it with diabetics, with monitoring blood glucose levels at home. So complications of surgery. Overall, 76%, which is insanely high, but it just tells you how complex of a disease this is. It affects the entire body. And there's a host of complications mentioned in your proceedings. I'm mentioning a few here that are I think, fairly, not common, but the ones that I've seen the most often. Kidney injury, coagulopathy. The cardiac one is a big problem. We're going to talk about that. Splenic thrombosis, peritonitis recurrence, 0 to 15%. If I have a recurrence on a dog, it typically is a dog that has comorbidities. It's got cancer, it's got endocrinopathy, maybe it's just older, it's got poor wound healing for whatever reason, Cushing's, what have you. And so I rarely will see it, and if I do, it's usually a pet that's got other issues where the healing is going to be delayed. So that's what I talk to owners about. Otherwise, I expect 0% recurrence post-operatively. Let's talk about cardiac arrhythmias. So ventricular premature contractions, VPCs, are the most common arrhythmia that we see. And so the question is, when do you treat those? So for me, I'm going to treat them typically to my own guidelines. And there's two scenarios where I treat them. Either one scenario is they're clinical for it. Doesn't matter if they have one VPC or ventricular tachycardia. If they are syncopal, pale gums, weak, missed drop pulses, drop femoral pulses, the dog is clinical for it, and so I'm going to treat the arrhythmia. The second scenario for me is if their ECG strip, let's say it's a minute long, has at least 25 to 30% VPCs in that strip, then I'm treating them. The problem with that logic, of course, is that if you're looking at a 1 minute strip or less, that's one check in time, right? You don't know what's going to happen the other, 24 hours, right? So it's a problem without continuous monitoring, but not everybody has continuous monitoring. So if you perform an ECG strip and either the pet is clinical for an arrhythmia or you're seeing 30% or more of the strip with arrhythmia, I treat. I typically start with procainamide, IM, because they're not eating right away typically, and then when they are eating, they get oral procainamide, but at the same time, I'm also using lidocaine. They get a bolus of lidocaine and they're on a continuous rate infusion from there. My goal with lidocaine is to get them off the base, right? So if there's cardioversion, the heart reverts back to normal rhythm, then I'm going to get them off lidocaine. I don't wean them off. You don't have to wean them off. Some people do. They feel better, but you don't have to. Well, lidocaine it is an analgesia, right? It's local anesthetic, and so it's going to cause neuromuscular weakness, which usually affects their gait. These are really old dogs with arthritis and other comorbidities, and it affects their gastrointestinal motility. They don't want to eat. They're nauseous, ileus. So I want them off lidocaine, but I'm treating the heart because, of course, that's of paramount importance, right? So typically I'm starting with bolus of lidocaine, a CRI, they're on injectable procainamide, usually IM, and then as they are improving clinically or with the arrhythmia on the ECG, I'm getting them off lidocaine, and then when they start eating, they're on oral procainamide, and then have them recheck in two weeks for the incision, and I'll do usually a spot check ECG at that time. If you have Holter monitoring, sure, but I typically don't. If the pet's not clinical for arrhythmias at home, when I see them to recheck, a new ECG strip, and I treat based on that. And again, it's a spot check, right? You don't know what's happening the other hours of the day or those 2 weeks, but you're doing the best you can with what you've got. This slide is intended to remind me to tell you that these dogs are old, right? They're old, they may be overweight, they're arthritic, they have all these issues. They're going to be recumbent after surgery. And recumbency after surgery is a risk factor for developing bronchopneumonia or pulmonary thromboembolism, PTE. We don't want that. We want to get these dogs up and moving around, but within reason, right? They're old dogs, they're debilitated. So I want them up. So if they're recumbent, then at least turn them over every 4 hours, right? Or keep them sternal. If they're somewhat ambulatory, short walk either outside for elimination purposes and to get them moving, get their tidal volume going, or if they're really debilitated, they can somewhat walk, but not for a long distance. Place them on a gurney outside, have them stand in the grass, maybe move around a little bit. When they're done, back in the gurney, back inside. Or if you really can't go outside, they walk around the hospital, the ICU, wherever. You're trying to get them up and moving around within reason, because you're trying to prevent things like bronchopneumonia or PTE. And ileus too is another risk factor. But we don't want to develop these things because we can prevent it. So keep that in mind as well. But if the dog is truly, really, you're not trying to force them to walk. The point is to do the best you can with what they're expressing to you. So the mortality in the literature is a wide range because this is such a systemic disease, multi-systemic disease. So this is sad to see that, but this is the way it is. It's a very critical condition. Survival can range 75 to 97%. With no surgery, 80% will recur, 80% will die within a year. These are surgical cases. There's really not many other options for these dogs. They have to be cut. And in your proceedings, there's a lot of different factors that affect mortality, but the ones that I typically focus on, how they present, the more debilitated they present to you, the larger risk of mortality. If they have to receive a splenectomy, the mortality goes up. Gastric necrosis, to me, is the worst factor for it. A lot of these pets do not do well after surgery with gastric necrosis. Lactate and other biomarkers are very popular. They do matter. However, I don't really use it clinically as much because if the lactate is high, I still have to deal with the same dog with a G.D.V. I will warn the owner that with a high lactate, we do know that morbidity may be affected by it, and also dogs with gastric necrosis can have higher lactate levels. So there is some prognostication there, of course, and your literature goes into a ton of detail on that. The papers on this are very complex because everybody measures it at different time points with the G.D.V. But lactate matters, but it's not affecting my decision making. I will tell the client why it matters, but that's about as far as I get. I don't go into the exact numbers because I still have to treat the dog for the G.D.V with surgery. And there are other biomarkers also in the proceedings as well that are less commonly talked about. So this is where you're at with the patient. These are all different stages. These stages have overlap as well. For postoperative monitoring, besides what we talked about with the cardiac monitoring, you're going to check their temperature, pulse, respirations frequently throughout the day. You want to weigh them at least once or twice a day, looking for water retention, any edema, ascites, respiratory watch, regurgitation watch. You want to get them up and walking at least every 6 hours, if not more often depending on the scenario. Protect your incision and your devices with the e-collar. Blood pressure, not only every 6 hours, you don't have continuous, but also every time you treat the blood pressure. If there's hypotension and you treat them, you need to check after your treatment. So if there's hypotension, you give a fluid bolus, you want to check after the fluid bolus to see if the blood pressure is improved. I know a lot of vets that don't do that, so think of that as well. Same thing with the ECG. If you're going to treat an arrhythmia, check the ECG afterwards, right? Monitor that stuff. It's going to affect your success rate. And then any other blood work arrangements, whatever you have to monitor for, you can monitor for after surgery as well. The antibiotic use we talked about with the risk of bacteremia and sepsis. I typically am going to cefazolin or cephalexin unless there's some other reason that I have to maybe go more broad spectrum. Maybe they have bronchopneumonia or they are septic, then I'll go stronger. Otherwise, typically cefazolin is the way to go until they can eat, and then cephalexin. Of course, we're going to be on IV fluids, maybe on colloids. We'll talk about procainamide and lidocaine. And then antacids, anti-nausea, and motility drugs also. Particularly with Serenia being so popular now as part of your pre-medication. So these dogs are really getting the gamut of things. So you're trying to recuperate them, get them home. Whatever analgesia you need. Keep in mind that analgesics also have their own side effects too. These are older dogs; they're very sensitive to these drugs. You don't want to keep them in pain. You also don't want to overdo it with the narcotics either. So there's got to be a balance there. You can always give a little more, but it's hard to take it away. Some are reversible, of course, but the point is, give analgesia when indicated. Palpate their abdomen, see if they're in discomfort. Are they tachycardic? Are they hypertensive? Are they vocalizing? Those are indications maybe that you need to have some extra analgesia on board. We don't want to ignore their pain. Keep in mind they are old and debilitated from the disease, and so you don't want to overdo with analgesia. And any other concurrent medications you need or any other arrangements they have, you can tackle those. So some final key points here, and then of course any questions you folks have. Prevention is the ideal, so you want to prevent them, those that are at risk at the time of stay and neuter, ideally. Of course, acute is what we typically see, but I want to point out that I do think there's maybe a chronicity to some of these dogs. I do think a lot of these dogs might have primary causes for G.D.V, so just keep that in mind. Those are my own thoughts that just want to have in the back of your minds. Delaying gastric resection, I don't know. I at least delay gastric resection in surgery, but I'm not going to wake them up and then cut them later on. I'm going to make a decision right then and there if I'm going to perform the gastric resection. Splenic biopsy, hepatic biopsy we spoke about, and I am going to touch base with concurrent surgical procedures. So we all had this happen where you have a G.D.V and they're like, hey, by the way, while you're there, can you remove this lipoma? And the dog is critical. So what I typically tell them is, yes, however, I have the right to abandon that plan. I can abort mission if I want to. It's going to be based on how the patient is doing. If the patient is doing great under anesthesia and surgery, sure, I'll remove that lipoma or remove the bladder stones or whatever it's going to be. However, if I don't like how the patient is doing, I have the ability to abort. So they will sign off authorizing those additional procedures, but I'm only doing it if I feel it's in the best interest of the patient. So it's not wrong to do it. It's just it's going to be a dynamic at the moment. Am I doing it or not? So I'm not against it, and we all know pet owners, they're going to want this stuff combined, but that's how I handle that sort of thing. And the same question goes to, if you're performing let's say you're performing a splenectomy for a hemoabdomen, and the question is, do you PECSI at the same time? Because we know that history of splenectomy increases the risk of G.D.V. And so I have the same answer. If the patient is doing well, I will PECSI. But there's no point in performing a PECSI and the dog is going to die from the hemoabdomen. right? So the spleen comes first. I'm doing that, or liver-vectory, or whatever you're doing. But the point is that at-risk patient, I'm performing the main procedure, the life-saving one, and if I have the ability, because the patient is doing well, to perform the PEC as a preventive measure, I will do it. Otherwise, I won't. I'll PEC them later, but I'm not going to risk the patient dying now because of convenience or what have you. So that's how I tackle those. And of course, there's veterinary after go for telementorship, teleconsulting for those who want it. Thank you again to Zomedica. Please visit their booth at 3:30. They have awesome stuff, as you can see. This is my contact information if anybody wants to reach out to me for any reason. And I'm happy to take on any questions, comments, concerns at this time. Thank you. Thank you. Yes?
When you're doing your gastric vaccine, do you have an opinion on the water?
Do I have a what?
An opinion on the water?
Barb suture. So when you're performing the gastric vaccine, do I have an opinion on the barb suture? I have no opinion, I have no experience with it. So have you used it? No. Yeah. Has anybody here used barb suture? Yes. What's your thought on it? Use it on skin? Not for PECing. And you like it? You love it?
Great.
You think great? Have you used it skin also, or just skin? Just skin. Anybody used it with viscera? So it looks like for skin we have winners, but yeah, not sure about that. Yeah. Do you see any problems using it in PECs? Would there be a contraindication in your experience with it? No? Should be fine. Yeah, so maybe more than a shot. I use typically I'm doing proline, so I want non-absorbable. I'm using zero proline. There are plenty of surgeons that will use PDS, which of course will absorb over 180 days, right? But theoretically performing a permanent adhesion well before 6 months. But I'm still doing proline because I'm scared. But you could. Yes. Do you see any complications of prophylactic PECs? Only one time ever I had colonic entrapment after prophylactic PECs. So like a horse stick, the colon will displace and get trapped. That's just a very annoying, unfortunate complication. Otherwise, no, I have not seen any complication with it. I've read in the literature things like abscesses forming, probably because they incide in the stomach, is my guess, and failure because either maybe surgical technique or what have you. But no, I haven't. And to me, it's worth doing. If you're comfortable with it, it's worth doing. In fact, to that point, if you are thinking about dabbling in PECs, I would suggest practicing on a cadaver. Whether it's an animal you euthanize and you've gotten permission from the client to practice, or whether you have a connection with a shelter, what have you, whatever it is. Practice is the kind of case you can practice on a cadaver before doing it in real time, because we all know access to care is a problem, and you don't have access to surgeons all the time. And if you're going to be cutting because you live remotely, or the clients can't afford ER specialty, whatever it is, cadaver practicing is a great way to go about this. Yes? Yeah? So the question is, does the incision length of the PECs matter? So I've always done it the same, but I don't measure it. I'm going for, my length of the PEC has to match the abdominal wall. So whatever incision I make in the stomach has to be able to reach the abdominal wall without tension, or minimal tension, right? So however that's going to be. But no, otherwise I don't. The number they quoted there, 2.5 to 5 centimeters, that's in the books. But again, a basset hound is different than Great Dane. So use your judgment. But I don't know. Does anybody perform a small PECs? Yeah, I don't know. I mean, if it works for you, if it has worked, then fantastic. All you need is adhesion forming. But yeah. So the question is, do I think the mastiffs need PECs? Any deep-chested dog, I would recommend it, but yeah, to be fair, I don't know if I really cut that many mastiffs. So she had 2 bull mastiffs that she performed the gastric PECs on, but is unsure if it indicated. I don't know. Is anybody here? Yeah, I wonder, I don't remember my proceedings if it mentions what % of dogs affected our bull mastiff sequence in there. Maybe that'll help persuade you, but yeah. Yeah, okay, yeah, I don't know. I don't see that many with mastiffs, but close to me where I practice.
And do you do speaking entities and the gastric
Do you do the splenectomy with the gastropexy if like the spleen has a rupture in it? Well, so if the spleen is compromised, it's coming out. And if it's a scenario where the dog is an at-risk breed for G.D.V and is stable, and I talk to the owner pre-op about it, I'll perform a pexy at the same time. If it's the reverse, where the stomach is the problem, of course we're going to pexy, and then the spleen I'm only removing if I'm concerned about it. I'm not removing the spleen if it looks fine and it's not compromised. But unlike people who heavily rely on the spleen to be healthy long-term, dogs don't. And I have to give a reason why I'm removing it. I'm not just going to remove it just because. Yeah. Yeah, you're welcome. Another question? Yes.
How do you feel about NSAIDs for GI surgery?
Ooh, how do you feel about non-steroidal anti-inflammatory drugs for GI surgery? I am not a fan of them in that scenario, but I know plenty of board-certified surgeons that'll use it. And as long as you can justify why you felt it was okay to use it, then I'm okay with it. I don't have a problem with it. But the problem is these dogs are coming in usually with vomiting, regurgitation, etc. So, and there is going to be gastric compromise. So I'm just not sure I see the benefit. We have so many good drugs, tramadol, gabapentin, there's newer drugs that I don't even use that are out there. But we all know that NSAIDs are a powerful analgesia as well. I'm not trying to discount them. But boy, it doesn't seem like it's worth the risk to me. Maybe if you do really want to use them, but you're too scared to immediately post-op, maybe you wait a day or two and then they can start them if they're doing fine, if they're eating by mouth and all that. But no, I personally don't, but I know surgeons who do. Yes?
What's your recommendation if the spleen looks okay, but the gastrosplenic ligaments torn,
And what was the last part?
and the things associated with it?
Yeah, so the question is, how do you feel about splenectomy if the gastrohepatic ligament, gastrohepatic ligament is torn and there's bleeding associated with it? If the spleen still seems like it's in, so first of all, I don't think I've seen that, but I mean I haven't looked hard enough, to be fair. However, if the spleen looks like the main vascular supply of the spleen is intact, the spleen looks and feels fine, I'm leaving it alone and I'll handle that. To me, that would be a great example for using ligature. It'd be fantastic for that. That way you can cauterize it and be done with it. But I haven't seen that scenario specifically in my own experience, but I also may not have noticed it. Yeah. How have you dealt with that?
I did a
Splenectomy?
splenectomy?
Splenectomy? So you did it as a prophylactic for splenectomy torsion?
Yeah.
Yeah. I mean, I can't argue that. The only time I've seen splenectomy torsion has been your classic English bulldog. I've seen it, I think, twice in my career, and that's it. I saw one splenic entrapment for an internal hernia, but that's not torsion either. Yeah, no, I haven't seen that exact entity, but yeah. My thought is like in that scenario, I want to keep the spleen if I can, But obviously there's hemorrhage, and you're just not sure, and you have one time to fix this dog. Then now's the time to fix the dog, and they don't need their spleen long term. The risk factor probably might be either splenic torsion or splenitis. If there is compromise to the spleen, then that's of course another surgery. If you talk to the owners about it, pros and cons, great. I call owners intra-op, by the way. I'll call if I'm not sure they're clear on something pre-op, or I'm finding something new, like let's say that scenario, I might call them intra-op, have them on speaker, like, hey, I gotta make a decision with the spleen. There's hemorrhage associated nearby. Here are the pros and cons of either. What do you want to do? And let them decide, and go from there. Yeah. Yes? Do I do laser for liver biopsies? I do not, but I'm also not experienced with laser. Yeah, so I don't. I try using, depending on the access points, ligature or guillotine method. Or if I really can't do either, if the liver's this big plump thing, then punch biopsy and use them in like Vetagel to take care of the hemostasis. But if I can find a nice prominent point, then a ligature or guillotine method. Yeah. Yes.
So I had a dog with a dilatation-volvulus, and anyway, I fixed it, he's fine. But then I was doing some reading, and it said dogs that have prophylactic gastropexy are predisposed. So then it got me a little bit more concerned about it. He had one, not by me. And I guess I'm just actually starting to wonder too if there's not more complications. I only do it in emergency. I don't do it in
the question is, and correct me if I'm wrong, she's had mesenteric torsion cases, and repaired them, but she also noticed in the literature that they've had a history of mesenteric torsion, they're prone to G.D.V. And so if you,
No. They're prone to the torsion because they had gastropexy.
oh, okay, so they're prone to torsion because they had a gastropexy.
Yes, and the only dog I've seen it in was the dog who had gastropexy.
I see. The only torsion you saw was one that had a pexy.
Right, and I don't do it prophylactically anymore. I used to, but I just felt that it was.
I mean, has anyone else seen a mesenteric torsion or any other serious complication from a prophylactic gastropexy? Yeah, I don't know. I mean, to me, it just sounds like bad luck if that's the case, because the problem is we call the condition idiopathic. We know these dogs have gastrointestinal motility issues, or perhaps the supporting structures are lax or whatever it may be, right? And so, but I don't see that. I don't know. And I can't recall reading that in the literature either.
And I don't know where I read it. It was
Yeah.
after it because I hadn't run into it before. And obviously it's kind of an emergency when it happens.
Oh, sure. Yeah, I mean, to me, it still seems that the pros of the prophylactic gastropexy are worth it for the at-risk group. Because it's so common. If you want to look at it from a defensive medicine standpoint, right? The CYA aspect of this stuff, cover your butt. You have to at least talk about it. It's an at-risk dog. It's a Great Dane or a German Shepherd, right? At least say, hey, Pexy, we can, or we don't have to. Here are the pros and cons of it, and let them decline or accept. Beyond that, it's based on your clinical experience with it. But as a surgeon, we're always being we're always under scrutiny because we're having higher prestige, whatever, and so they expect more of us. So it's all about client communication and documenting your conversation. So I would say have the client decline the prophylactic gastropexy. Having declined it is better than having you not offer it, and then
Oh, I know, I offer.
yeah, and then 6 years later they're like, hey, why didn't you tell me? To me it still seems worth it to perform it if it's an at-risk dog. I mean, is anybody here resistant to offering a prophylactic gastropexy for any reason? Outside of finances or whatever, Yeah, just not convinced. Mesenteric torsion is so rare, so it's just. And colonic torsions, yeah, but it's not common.
The other day, they had radiographs 2 days before, and the vet came in and I was like, whoa.
And so radiographs 2 days before the colonic torsion, they were normal radiographs?
Yes.
Yeah, it's a peracute condition, and I've only seen those be used knife on the table. It's just necrotic, everything. So the fact that you got the fixed one is kind of cool. They made it.
Yeah, it was my own dog, of course.
Your own dog? Your personal dog? Oh boy.
That's the reason why, because literally.
Oh my god. That's bad luck.
Everything's blocked. I mean.
Yeah.
I thought I couldn't remove everything.
Yeah.
So I untwisted it, sewed him up, kept my fingers crossed. It did pink up, but I was still really worried because I've never seen all the blood vessels be blocked.
And he made it?
Yeah, but
That's cool.
It's a
It's a lab, of course. Yeah. Did you notice any arrhythmias once you detorsed it?
No.
Yeah.
No, actually, he was extremely stable, and I feel that we caught it extremely quick.
You found it early, yeah. I mean, so when you detour something that severe, what I've seen, the few times I've seen something like that, I will see the heart rhythm go from normal to VTAC in a second. It's so fast. So if you have like a splenic torsion, for example, obviously don't unravel it. You're going to remove it and block. Because the oxidative injury from that is immediate. And it's like VTAC and then they're arresting, So you must have caught it at the right time. That's crazy.
Yeah, no, I feel that we were really lucky. If it wasn't my dog, my husband would have been so nervous. He's like, he's off. I'm like, don't bring him in. So we brought him in within an hour I was having.
Wow.
Wow.
Okay. Any other questions? Anything else? Yes.
So one of my babies had a CKD after death and failed tours. It's not getting better, but it's CKD. She's just doing the same stuff for 3 months now, like blood works every month. It's not getting worse, but it's not getting better either, I guess.
The chronic kidney disease happened after you,
Anesthesia.
but before that, the renal values were normal. And this is your own personal pet. Boy, you guys and your personal pet, what the hell is happening?
That is
Yeah.
so weird. I did my ultrasound, radiographs, everything. I don't find any answers still. I don't know why she beat up though.
Yeah.
She was down to 80 pounds, now she's 140 again.
I mean, I guess anesthetic, you know, I mean, I guess I would look at, like, what's your typical protocol? Tilazol? I mean, I don't know. I mean, my thought was go to adequate fluid, administration during surgery, during the initial surgery, right? Yeah, making sure they're covered for, yeah, I don't know.
I've never seen that before.
Yeah, then I don't know, and it's your own pet. Thanks, guys, thank you.